Morning everybody. Just going to kick things off talking about anterior cruciate ligament ruptures. A summary of what I'm going to talk about today, a little bit about anatomy and biomechanics of the ACL, some epidemiology, presentation of how an acute ACL rupture presents, the principles of management, and then I'll go into surgical techniques for ACL reconstruction and touch on rehabilitation. So the ACL is an intracapsular but extrasynovial ligament. It is supplied by the middle geniculate artery and also the posterior articular nerve, which is a branch of the tibial nerve. It's well known there's two distinct bundles of the ACL, the anteromedial bundle, which is tight in flexion and provides AP stability, and the posterolateral bundle, which tightens up in extension and contributes to rotational stability of the knee as well as AP stability. The ACL is approximately 3 centimetres long with a width of 1 centimetre, and its strength is approximately 2,200 newtons. Its main role is to resist anterior translation of the tibia and rotation. So here's some pictures of the anteromedial and posterolateral bundles of an anterior cruciate ligament. I think one of the more difficult concepts to look at and get familiar with is the femoral insertion of the ACL. So it inserts into the medial aspect of the lateral femoral condyle in the intercondylar notch, posterior to residence ridge or the lateral intercondylar ridge. Its insertion is vertical when the knee is in extension, and with flexion the posterolateral bundle comes forward in front of the anteromedial bundle and the insertion becomes horizontal. So horizontal in flexion, vertical in extension. The tibial insertion arises the name of the bundle, so anteromedial and posterolateral, and it's lateral to and anterior to the medial intercondylar spine. A little bit of background of the incidence of cruciate ligament rupture. It's relatively common. It's more common in females, approximate ratio of 5 to 1, but this number varies significantly in the literature. It's a non-contact pivoting injury, often with the foot fixed to the ground and a valgus twist action. The reason for that female ratio is thought to be related to smaller ligaments and a smaller notch and a smaller knee, but also the relative valgus position of a woman's knee, especially when landing. Associated injuries with acute cruciate ligament rupture include medial collateral ligament injury. Approximately 60% of ACLs have an associated lateral meniscal pathology. Bone bruising of the lateral femoral condyle is common and often seen in MRI, and fracture can be also seen, namely a Sagon fracture, a Volscian type fracture. Medial meniscus pathology is more associated with a chronic rupture, but can also be seen acutely. A little bit more on the background of ACLs. So this is a Medicare, there's no joint registry or anything that looks at ACL reconstructions, but these are the Medicare figures. So in 1999, 5,000 ACL reconstructions done privately, 17,000 or 18,000 done in the public scheme, 280 done in the public scheme, and then you come across to the privately done ACLs and it's come up to 8,600, and the number of MRIs we're doing for ACLs is grown by 300%. So, sorry, these are only the private figures for the Medicare rebate, but you can see there's been an explosion in the growth of ACL reconstructions.
Medicare
So the presentation of an anterior cruciate ligament, there's often an audible pop and a giving way of the knee associated with an immediate inability to weight bear, and a swelling, acute swelling associated with a hemarthrosis. When you type in mechanism of ACL tear into Google images, about 300, the first 300 are not 80% female soccer players. So I think that's kind of your typical injury that comes across, but none of them showed the mechanism particularly well. So there was just a lot of pictures of female soccer players. The differential diagnosis for an acute hemarthrosis includes a PCL injury, osteochondral fracture, meniscal tear, or a capsular tear. On examination, there's an effusion acutely with a positive patellotap swipe test. You have to look for other ligamentous injuries. Anterior draw, the anterior draw Lockmans and pivot shift are going to be difficult to interpret acutely because of pain, but they are often positive. The Lockmans is the most sensitive test for an ACL rupture and is performed in 20 to 30 degrees of knee flexion with the tibia slightly externally rotated. A positive test is defined as having a soft, mushy endpoint, and it can be graded as 1, 2 or 3, with 2 and 3 being definite ACL rupture with a mushy endpoint. Pivot shift is described a number of ways in the literature, but essentially is with the knee extended and applying a valgus and internal rotation force on the tibia. With knee flexion, the iliotibial band reduces the tibia from a sublux position anteriorly. And that's thought to be a more specific test for how the knee is going to behave after reconstruction. And the KT1000 test is essentially a Lockman's type test that can measure the degree of anterior translation of the tibia, so is very helpful for literature. So investigations in an acute ACL rupture. So a plain X-ray may show an effusion, a tibial spine avulsion, fracture, particularly in a paediatric and teenage age group of patients, or a Sagon fracture of the lateral aspect of the tibial condyle, which is associated with the lateral capsule avulsion. MRI shows an empty femoral tunnel in the notch, femoral attachment, and you lose the straight continuous fibres of the ACL, and there's often a lateral compartment bone bruising of both the tibia and the femur that is increased signal on the T2 MRI. So at the top here we have a normal T2 of a knee. You can see the nice straight fibres of the PCL of the ACL on both pictures and the PCL at the back. And on the next group of images, you've got lax looking fibres and you've got an empty lateral femoral condyle intercondylar notch. So lax fibres, and there's also some evidence of effusion and inflammation and some bony bruising from the T2. So management principles of acute anterior cruciate ligament injury. So non-operative management can be considered and might be the right choice for a number of patients. So depending on the patient's activity level, there's a wide variation in the incidence of functional instability in patients that have had an ACL rupture. And progression to OA is also quite variable. In a 2008 study, it was a cohort study, it was associated with approximately 20% incidence of osteoarthritis seen on X-ray at 15 years. And this was actually higher than the cohort that had reconstruction. But in previous articles it has been quoted that osteoarthritis is associated with non-operative management. And it is well known that a medial meniscal chronic tear is associated with an ACL deficient knee. Operative management should be considered in young active sports people, although the newer literature support shows that there's a lower expected return to high-level sport, even in experienced surgeons. And I think it's worth noting that it's still associated with osteoarthritis. Reconstructing an ACL deficient knee is still associated with OA, especially when using a patella ligament reconstruction, which I'll go into a little bit later. So there's a number of choices in terms of your graft choice for reconstruction. The most common would be autograft, which includes bone patella bone reconstruction, and hamstrings, which is the more commonly used autograft seen in this institution. Australian authors from Sydney recently published hamstrings as the new gold standard and should be considered the gold standard in terms of choice of autograft because of the association with less donor site morbidity. They cited an association with patella baja in bone patella bone grafts, which was also associated with long-term OA in bone patella bone knees. And while they admit there's a slightly increased re-rupture rate on hamstring versus bone patella bone, they've actually quoted that bone patella bone has the same overall incidence of re-rupture, but they have a higher contralateral re-rupture rate, which doesn't make a lot of sense to me. Quadriceps can also be used as an autograft and as a strong graft. In terms of allograft, I guess I've never seen it used, but it is associated with that less donor site morbidity, but offsetting that is high failure rates, and it takes longer to get ingrowth, and there is an infection risk associated with allograft of 1 in 1 million, but it's still a theoretical risk of viral transmission. Synthetic ligaments can be used and have been used quite popular in the past in a number of high-profile sports people. It's initially very strong when it goes in. It's not going to get any stronger than the day it goes in, but has been associated with synovitis in knees and has also been well documented to have high failure rates. A recent meeting of knee surgeons in Australia, only 2 of 150 surgeons in the room had used LARS for a primary ACL repair in the last 12 months. So that was last year. So that gives you an idea how much it's fallen out of favour for acute ACL injury. Operative management of ACL rupture. I'd like a little bit about tunnel. So tunnel malposition is the most common reason for failure. Double bundle versus single bundle technique I'll go into a little bit later on, but essentially that means either single bundle technique is recreating both bundles with a single graft, and double bundle is trying to recreate both the anterior and medial and the posterior or lateral bundles of the ACL. It's worth noting there's no true isometric point of the ACL, so there's no isometric point to put in your single bundle. Transtibial technique versus anteromedial portal. So I think a lot of the literature at the moment supports the use of an anteromedial portal, so you can get a more horizontal graft, and a transtibial technique is associated with a vertical graft position and rotary instability. So the idea is to try and restore anatomy. So a femoral tunnel, if it's too anterior, is loose in extension. If it's too posterior, is loose in flexion. And if it's too vertical, it gives that instability I talked about. And tibial tunnels are also important. So too anterior tibial tunnel can lead to impingement at the notch, and too posterior position can be associated with PCL impingement. So this is just I think diagrams are best for showing the ACL anatomy. So this is the residence ridge or lateral intercondylar ridge here, and there's a bifurcate intercondylar ridge between the anteromedial insertion and the posterior lateral insertion. And just to get your bearings in terms of position, especially in flexion and high flexion, the position we're often in during the operation. So proximal still refers to out this way, anterior is up, posterior is down, and distal is towards you when inserting your, doing your femoral tunnel. And again, another couple of pictures. So this is a sagittal section of a left knee, a cadaver section. So again, knowing that posterior lateral bundle becomes anterior with the knee in flexion. And the blue line's the lateral intercondylar ridge. And those pictures again with the femoral tunnel. There's a number of fixation techniques for ACL and instrumentation, which I haven't talked about. There's a huge variation in instrumentation from each of the companies that you can use as guides for your tibial and femoral tunnel insertion. But in terms of fixation techniques, broadly they can be classified as either interference, screw fixation, cortical fixation, and cross-pin techniques, and a hybrid of those can be used in any one surgery. So interference screws are, such as RCI screws, they can be metal or biodegradable, and they involve sliding up alongside the graft and screwing in your screw and getting wall fixation in your graft tunnel. Cortical fixation, so endo-button and easy lock are both used at this institution. On the femoral side for cortical fixation, and a newer technique which I haven't seen used is cross-pin fixation, which has recently become more popular, but interestingly there's some questions about its fixation properties in the literature, and I think probably should be there should be more studies done before that's widely adopted. In terms of rehabilitation, I think the most important thing about rehabilitation is prehab for ACL knees. So it's very important to achieve full range of motion prior to surgery, and this is associated with a significant decrease in the stiffness of the knee after the operation. Early post-operative therapy. So a lot of this was done by Shelbourne, which is a US surgeon who's developed a lot of guidelines for rehabilitating an ACL. He is the patent holder of ChiroCuff, so aggressive ice therapy is recommended for ACL knees and is associated with better outcomes. Encourage early full range of motion, focusing on initially passive extension and closed chain exercises in the early post-operative period. So this is with the foot planted, and a number of articles of recent times have recommended avoiding open chain exercises, especially towards terminal extension, where this is thought to be put the most strain on the graft, but in the last 15 to 30 degrees of extension with the foot free. And then there's a focus on returning to normal gait, increasing strength. And there hasn't been a lot of difference shown between accelerated and conservative rehabilitation programs. And Shelbourne actually noted that a lot of his patients that were ignoring his more cumbersome rehabilitation guidelines were doing better. So it's okay to go a little bit quicker than I think was first thought. A return to sport is roughly recommended when there's nil effusion, good strength and nil instability. So good strength of both hamstrings and quadriceps and nil instability of the knee. So complications of ACL reconstruction, the most common reason again is for aberrant failure is aberrant tunnel position, which can also cause impingement and a decreased range of motion. A stiff knee is associated with acute reconstruction. Anterior knee pain is well recognised to be associated with bone graft harvest. Hamstring weakness is seen with hamstring harvest. Saphenous nerve injury can be seen, and also there's a risk of infection with any operation, but the risk of autograft viral transmission is approximately 1 in a million. Another couple talking points. So leaving the ACL stump, benefits are that you theoretically get better vascularisation of the graft, and there's proprioceptive properties in that ACL stump. So by leaving the stump there, there's potential benefit in having a better functioning knee after the operation, but that leads to a more difficult view, and we've already noted that tunnel position is the biggest factor in an ACL knee doing well. So a view is important, and it can lead to a cyclops lesion in the intercondylar notch post-operatively. The double bundle technique, there's logical rationale for replacing two bundles with two bundles, and we've already said there's no true isometric point of the ACL. It's supported by biomechanical studies and cadaver studies, and is shown to be associated with greater rotational stability. The disadvantages for this technique is that there's already good results for a single bundle technique, and there's no randomised control trial showing that a double bundle technique does any better than a single bundle. It makes for a more difficult operation and more difficult revision surgery, and potentially for that reason again has more complications and more donor site morbidity, and it also has a longer surgical time. At the Western, looking at our audit, we do about 1.5 reconstructions a week. I think everyone is on board with a delayed reconstruction. The majority of surgeons use ipsilateral hamstring graft, a single bundle technique, and again, more commonly an anteromedial portal is used, and the femoral tunnel is drilled in a hyperflex position, and a variety of fixation techniques are used, but an RCI screw is, I think, commonly used on the tibia, but there's a variety of fixation techniques used at this institution, and we often put patients in a Zimmer knee splint post-operatively, either for 2 weeks or until physio thinks they've got adequate quads control to safely walk. And I guess we don't know what the results are doing, but I think in terms of the literature, this is a very good, well thought out technique that's well supported in the literature, so we should be expecting very good results with this technique. So in summary, it's a common injury. Surgery is becoming increasingly popular. You need to expect associated pathology. There's a variety of techniques that can be used. There's a variety of grafts and instrumentation that can be used to reconstruct the ACL, and failure is most commonly associated with improper tunnel position.